Okay, so a GI endoscopy allows us to be able to see the inside lining of the digestive tract. Um, is performed using an endoscope, which is a flexible fiber optic tube with like a little tiny camera at the end of it, and it's hooked up to and like an eyepiece, kind of like goggles that the surgeon can actually view just himself, or it's hooked up to like a TV, so it would display the images on that. Endoscopies are performed outpatient or inpatient. We can evaluate several problems such as ulcers, cancer, polyps, things like that. Depending on which portion of the digestive tract itself that's being looked at, determines the name of the procedure. So, in upper endoscopy, shows the esophagus, the stomach, and the upper small bowel, known as the duodenum, which is right over here. A colonoscopy allows the doctor to see ulcers, inflamed mucus lining of the intestines, abnormal growths, bleeding in the colon or in the large bowel. And that would go with the endoscope up through the anus, down that way. That's also could be a sigmoidoscopy as well. So there's another one. It's an enteroscopy. It's a recent diagnostic tool that allows the doctor to see the small bowel. We can diagnose and treat hidden GI bleeding. It can detect causes of malabsorption. It can confirm problems of the small bowel that we saw on an x-ray. And it can be used to locate and remove sores with little damage to healthy tissue. So that's a positive to that. There are other tests, but none of them really offer a direct view of the mucus lining of the digestive tract, which is really nice about endoscopies. There are risks, though they are rare, such as bleeding, puncture of the esophagus or the stomach walls, irregular heartbeats, respiratory depression, infection, fever, dehydration due to laxatives that are used, especially with the colonoscopy and the sigmoidoscopy, or the enteroscopy, cardiac arrhythmias, infection, especially, or bleeding, especially after like the biopsy of, or like the polyp is removed, perforation of bowels, and even explosion from the gases that are located in the colon. To prepare for an endoscopy, so first we want to make sure that our patient has signed an informed consent. If not, we want to witness them signing one. We want to have a baseline set of vital signs just to compare to for after surgery to make sure that they are responding well. Obviously, there are other things as well. You want little precautions like stop taking medications such as like aspirin or sulfate, which is used to treat ulcers. Those could cause false readings on the tests. Patients that have cardiac valve replacements or blood vessel grafts should receive antibiotics to prevent infection as well. You want to be NPO for 8 to 10 hours before the exam. That allows a valid exam, and it also decreases the vomiting risks from the anesthesia. A topical anesthetic for like the upper GI ones to numb the throat, and that helps prevent gagging. The other tests, like all the tests too, there is mild sedation as well. So you want to make sure that your patient has a ride home after the procedure. For a colon or a sigmoidoscopy, you want to make sure the rectum and colon are completely cleaned of all fecal matter. So you want to change the diet prior, so no fibers or food with small seeds for about 5 to 6 days before the exam. And you want to drink liquids such as tea, juice, clear broth the day prior. Laxatives, 12 to 15 hours before the test, about 4 liters. Some of the laxatives are polyethylene glycol, magnesium citrate, Senna, Miralax, those are the most frequently used. There's small volume preps also, which is a soup prep or Prepopic. They may have like 1 to 2 enemas 2 to 3 hours before the procedure. Sodium phosphate is the only pill form prep available. That's Osma Prep. You want to make sure some patients avoid that because it has a risk for kidney infection, such as patients with heart failure, end-stage liver disease, renal insufficiency, inflammatory bowel disease, electrolyte abnormalities, patients on diuretics, and patients on non-steroidal anti-inflammatories, and patients over 65. They should avoid the osmo prep. And then, so during the surgery, they'll be positioned, depending on the procedure, they'll be positioned different ways. And then after the procedure, you just want to keep a close eye on bowel sounds, respiratory, on labs for like white blood cells. Make sure there's no infection, no fever, no abnormalities based off the baseline vital signs that you took when they got there. And again, make sure they have a ride home because there is mild sedation. And that's it.